Hello, welcome everyone. Hello, hello. Great to see you all. Why don't we start off by you can put in the chat where you are joining from today. We have a pretty global cohort, so it's always fun to see where everyone is. Welcome, welcome. Anyone joining from no one yet. No, everyone is shy. Okay. Ooh, Wilnice raised her hand. Let's see. I don't know if I
Melly, someone wrote that
Hello.
the chat is disabled.
Yeah,
Oh,
that's what I wanted to say. So,
got it. Okay. Thank
yeah,
you. Thank you.
but I'm from Oregon.
Yay.
Wilniz, welcome. Wilniz was part of our first cohort.
Oh, cool.
All right. So I wonder if we can get started. I think that a lot of people are already in here. So welcome to this webinar. This is part of the series of webinars that we hold to raise interesting topics around substance use disorder, innovation, technologies, and practices. This is part of the bigger mission that we have to really bring SUD innovations to market and commercialization, working together with the National Institute of Drug Addiction and MIT. And here today is Brandi Fink. She's a professor at the University of Oklahoma, but most importantly, we know her as one of the participants of SUD Ventures Cohort 2. She has spent a lot of time working on the issues of substance use disorder, treatments, and in different modalities. And specifically today, she wanted to share her story working on a technology that is really appending the alcohol management in the primary care settings. Brandi will talk about generally the space and her experience of developing and funding and kind of getting this idea and prototype and then technology to the users. And this is mostly an open session. So after Brandi presents her story, we'll have ample time for Q&A. And if you have any questions, we do encourage you to share them in the chat or actually better in the Q&A section. I believe we'll make sure to get to as many of them as possible. At the end, we can also take some questions about the SUD Ventures new program in the next year. So if you have those questions, please save them for later. So I'm very excited to welcome Brandi, and thank you so much for your time, and thank you everyone for attending, and looking forward to learning more.
Yeah, well, thank you so much for the invitation to talk about this. I had such an amazing experience at the SUD Ventures Boot Camp, and I really walked away feeling like I know the whole path forward to taking this product that my collaborators and I have been working on for a little while now to market. So it's kind of exciting for me. And so I thought I'd just kind of give some background of how I came to care about this issue. When I was at the University of New Mexico before I came here to OU Health Sciences 3 years ago to help build up their substance use treatment and research here. And I had a career development award, so that gave me protected research time. And then I had just 1 day a week where I was integrated into primary care to do substance use treatment. And I was so excited about this opportunity because, we have, well-established interventions for high risk, especially high risk drinking in primary care that has great outcomes for patients, can reduce drinking to low risk levels. And I thought this is going to be great. And so I am in the primary care clinic. And so, I give my spiel to my colleagues there, and we talk about the public health problem that hazardous and harmful drinking presents. It costs the US about $249 billion annually. And we have a population strategy for intervening with alcohol problems that we've been doing this for nearly 40 years now. And so when I was in the clinic, I talked to my colleagues about, here are the measures we'll use to screen. When you identify someone with high risk or harmful drinking, I'll be able to come in and talk to them about their drinking and provide some intervention. And I heard crickets, absolute crickets. And I was only ever referred a patient who was on the severe end of the spectrum of drinking or opioid use or anything. Nothing about our hazardous or harmful drinkers. So being integrated in the clinic gave me a really unique perspective on why this wasn't happening. So even though this has been the population strategy since 1979, we really aren't making any inroads into improving the delivery of a screening and brief intervention in primary care. We're doing much better now at screening because our EHR systems have the patient portal where patients can complete like an audit C or a complete audit to do their screening. And so we've improved at that point, but we are still way behind in delivering the brief interventions to patients. And so when we are talking about this harmful or hazardous drinking and why this should even be addressed, of this $249 billion that alcohol problems cost the United States annually, and this is a figure that's about 15 years old. We don't have any updated costs on that yet. 78% of that cost comes from people who are drinking at harmful or hazardous levels. So there is significant reason why we should be improving our intervention in primary care. But and so what we want to do with these brief interventions is get people down to a low risk level of drinking. So that would be for females under 3 standard drinks at one setting, for males under 4, and weekly no more than 7 drinks for females and no more than 14 drinks for males. So drinking at these hazardous or harmful levels puts people at increased risk for accidents, violence, uncontrolled diabetes and hypertension, significantly increases their risk of cancer and things like that. So we have, lots of impetus to reduce drinking. And we know that at least 20% of primary care patients are drinking at these hazardous or harmful levels. So, I was so disappointed when this wasn't, when I wasn't being referred any of these patients to intervene with, because these interventions are so highly effective at reducing people to low risk drinking. For instance, they can reduce drinking by 8 standard drinks a week. So that is pretty impactful when it comes to a person's health. And so being embedded and integrated in the primary clinic, I could really see why this wasn't happening like it should. For one, I'll start at the bottom. There's a lack of provider time. Sometimes these interventions can take, 15, 20 minutes, and that is the max time that a provider has with a patient. Some providers have a lack of access to valid screening. So depending on the health system the person is practicing in, they may not have access to the screening tools. And they really probably don't have any training in the brief intervention materials as well. At UNM, we were kind of unique. I did training for medical students and how to conduct a brief intervention, but I know here at OUHSC, even our primary care residents get zero training on this, or even how to screen. And then there's the reluctance to raise the issue in a routine visit. So if somebody is presenting there with for diabetes management or a check of their hypertension, or they're presenting because they have strep throat or something like that, providers feel kind of weird about raising the issue of how much the patient was drinking. So I could see all of these things. And at the same time, my career development award was through the Clinical and Translational Science Center, and NCATS funded KL2. So at the Clinical and Translational Science Centers, there is a whole core that is focused on commercialization and bringing known research to market faster, because at a minimum, it takes like new behavioral interventions, a minimum of 7 years from when the last clinical trial was conducted to when the new intervention is, routinely used. And so I'm in this environment where people are doing this as well. And so I'm attending, weekly and monthly talks about commercialization, and everybody's got something that they're working on. And I was kind of also like, I want a thing of my own as well. So it was kind of a really unique confluence of factors that brought me together to develop our personal alcohol management system with my collaborators. And so with PALMS, is what we called it. We tried to name it something accessible, and like we were giving a helping hand. We sought out a biotech firm in the Albuquerque area at the time, and they helped us develop the actual product itself. And then we applied for a small business research or innovation research grant through the National Institute on Alcohol Abuse and Alcoholism, and were awarded it. So we set about developing our product. And so what we did here is patients were given an iPad when they checked in for their appointment. And then they could just sit down in the waiting room, and we use machine learning and artificial intelligence to do the screening using validated measures. And then depending on how the patient screened, we delivered a brief intervention as if a person was sitting there with a clinician doing it. So we used the standard frames model, which is a well-known established model for talking to patients in primary care about their drinking, and did this with patients. And we had tested our product with 235 patients in primary care. And then we did follow-up usability and feasibility measures with it. So the other unique thing about Palms, so not only did we intervene with the patient while they were waiting for their provider, but then we fed the information to the provider about how their patient screened and what we did, and then what they needed to do next. And that was the part that surprised me, how much the providers loved that. They were like, just please tell us what we're supposed to do. So, for example, if we had a patient who screened as low-risk drinker, we let the provider know that they were a low-risk drinker, and what the provider needed to do then was screen again in a year. If the patient, let's see, is scored as hazardous drinking, we provided the brief intervention, told the provider, and recommended the provider screen the patient again in about 3 months. And so the providers loved this part. The other group that also loved this was the hospital administration and the clinic administration, because, and I didn't anticipate this coming in, but then they were able to demonstrate to their accrediting bodies how they were managing these high-risk patients in their clinic. So they were really excited about it as well. Excuse me. And so, as I mentioned, we did acceptability and feasibility measures with this, and we scored outstandingly with the patients. So the patients really liked doing this. They liked doing it in the waiting room while they were waiting for their provider. And overall, they felt that the software delivery of the product was very acceptable. And we got ratings of acceptability of 1.43. So that's on a scale of 1 to 5, with 1 being highly acceptable. And then our feasibility score was an 87. And so a score over 80 is a really well-liked software type system that people will often then tell their friends about. So we were really happy with how this went. And so now we're in the stage of developing our phase 2 application, where we'll actually do a clinical efficacy testing, so a non-inferiority trial, to ensure that this product is reducing high-risk drinking, just as if a patient was sitting there with a clinician doing it. So we're in the process of that. Hopefully we'll submit our application in the September round with that. And just last, I'd just like to acknowledge my funders and my collaborators as well. You know, as I mentioned, we got our SBIR grant through the National Institute on Alcohol Abuse and Alcoholism. I had some additional funding from NCATS as well. And then my collaborators, Gilberto Zamora and Randall Starling, Gilberto's at Vision Quest Biomedical, and Randall Starling's still at UNM. And I just have my email address on there. If I have anybody wants to follow up with any questions or anything. And so I'm happy to discuss further or answer questions.
Thank you, Brandi. Thank you for sharing this. I have a first question, but also if there are any questions in the audience, this is the time to share them. So you mentioned you have been able to fund the first stage of the development of this tool through an SBIR award. I guess it was phase 1. And
Yep.
can you tell us more about where you are right now with the process of taking this to market, and any kind of challenges or particular areas of commercialization that you're looking to solve right now?
Yeah, I think probably why we didn't apply for the phase 2 SBIR, which is a much larger grant. It's about $1.5 million to be able to do a multi-site trial, is I felt like I had a gap in my knowledge about how to do the whole venture thing and move it into market. And I feel like I had those questions answered when I attended the boot camp, to be honest with you. And just being able to talk to the coaches we had there, as well as looking at, and learning about what other people did with their own ventures and things like that, and the lectures that we had, I feel like I really appreciate the entire process now. So one thing I've done since I have changed institutions, and this is a thing to deal with, is the intellectual property around this. When we submitted this, UNM owned the intellectual property. So I went through a process of obtaining that intellectual property now, and my collaborator, Randall Starling, and I have another collaborator, we have formed a startup company. So now the company itself owns the IP with this. And so we can then apply for the phase 2 through our own company. We will be looking for a new developer, Vision Quest Biomedical. I mean, we're great group of people, but their focus is on imaging for diabetes, so retinal imaging and things like that to detect diabetes early. And so their board of directors felt that being engaged in this project was too far afield from their, central focus. So they also gave me the IP for that. So our company will be the one that will be applying for the phase 2 application and testing that in primary care clinics here in the OU health system so far. So that's kind of where we are standing right now, plus writing up the application for the phase 2.
Thank you, Brandi. We have one question. I have more questions myself, but we'll take the question from the audience, from Dallas Wenteman. Sorry if I'm not pronouncing your name correctly. It's asking whether you can talk a bit more about how brief advice is delivered, and is there any involvement by the primary care physicians, who and how it's delivered, and any follow-up activities. I guess maybe more details about what you've already discussed.
Sure. Yeah, so brief interventions we like to use, and I made mention of this, the frames model. So you give feedback about what the drinking is, that, let's say they scored a 12 on the audit. So they are evidencing some high-risk drinking. 8 or below is low-risk drinking on the audit. So the patient is given feedback about it. and that they're drinking at, such and such percentile, maybe the 80th percentile, which means that 80% of individuals in the United States are drinking less than this. This is what is a very impactful intervention. And then we give them resources. That's what the R stands for. The A in the FRAMES model stands for advice. So we give them advice. You are a female, and so it's recommended that for females, you don't have more than one standard drink. And we gave them exactly what those are. So that's a 12-ounce beer, like a Coors Light, 5 ounces of wine, or 1.5 ounces of hard spirits. So if you're having, for example, a Long Island iced tea, that can have up to 5 standard drinks in it. So it's important that, what a standard drink is communicated to the patient. And then we give them a menu of options, how to reduce their drinking. And I'm completely blanking on the E right now. I should have looked this up before we came in. And then we told the patient what we are telling your provider. So this information in the phase 2, we will use API and come in and plug in to the back of the EHR, so that this can just run seamlessly in the electronic health record in the clinic. And then the provider will have the information about the patient's drinking, what we did, and again, what they need to do with that. And that's kind of basically how a brief intervention goes with patients. Now, if someone is drinking at or at a very high risk level, or showing some symptoms of dependency, then that warrants a referral to resources, a referral to treatment. That's the RT and the SBIRT. And this is preferred to be done, not just giving the patient, here is a place you can call to go and get help for this, but actually reaching out to a center, getting information, and helping the patient decide if this is the right place to go and get help. But at that point, they need an assessment done by an addiction specialist, and potentially engaging in alcohol use disorder treatment, to include medication at that point.
Thank you, Brandi. Actually, 2 more questions that kind of related to what you just said. One is, for sure, this intervention is for, when it's not yet, for cases when they're not yet classified as necessarily substance use disorder. It's a population screening. But the question from a TP Duga, if there has been any new treatment protocols for alcohol use disorder, and I'm not sure if you're aware of the latest. I know you're working in this field, but it's pretty broad.
Yeah, it's broad. Like, I have a line of research focused on family-involved treatments. So we have our standard, like, relapse prevention. There's mindfulness-based relapse prevention, and then motivational interviewing and things like that, all with a good, strong evidence base. We also have family-involved treatments where we can do treatment with the dyad, like the identified patient and a concerned significant other. Those have great effect sizes above individual treatment, but they're long and complex, and the uptake is not very good. So one area that I'm working in right now is we have distilled down Barbara McCrady's alcohol behavioral couples therapy into 3 essential sessions. And I'm testing that with a collaborator at MUSC in a completely telehealth remote study with veterans. And I have an application under review at NIAAA right now to see if we can use BFIT, is what it's called, brief family involved treatment, to increase engagement in alcohol use disorder treatment for patients, hepatology patients with alcohol-associated liver disease. Very, very ill folks with lots of resistance getting into treatment. So we're looking to see if we can increase treatment there. So I hope that gives kind of a smattering of what's available out there.
Yeah, thank you. And somewhat related question for this specific POMS, I guess, intervention, Maria Markitanova is asking, what kind of treatments do you refer them to? And is that the treatments connected to the clinic, or is this something outside of the clinic?
It would just depend. Here, like when we do our phase 2, we have our comprehensive addictions resources, education and services clinic, our CARES clinic here, where we provide evidence-based comprehensive substance use treatment. So we would be happy to refer patients for an intake here at this clinic, but it would just depend on where once, let's say this gets commercialized and people are buying it, that would be part of the service, is identifying what are good evidence-based treatments that would be appropriate for referring patients to in whatever area.
Thanks for clarifying. And actually switching gears a little bit more towards commercialization, the part that I'm interested in. I know you mentioned that you now you have secured the IP for this product and you're interested in taking this forward. But what are some of the key areas where you're looking into, to move it to the next step? Is it securing more locations? Is it product development? What are the things? That maybe something else that I'm not.
Yeah, some assistance with product development. I think we have a good framework to step off of, but that was a beta version essentially to test the acceptability and feasibility of it. And it was still a product that existed outside of the electronic health record. So now if here in the States, most people will check in, a day or two for their doctor's appointment, and they'll do it through the patient portal and answer questions and things like that. And that's where presently would be the ideal place to have the product exist and be delivered to the patient before they show up to their primary care provider. And then the information from that is just available to the provider when the patient presents. And so the patient will be told what their drinking is and what needs to be done with it at this stage. So did I answer enough of your questions?
I think so. And there's a question from Manuel Rebol, who is asking whether you think this tool could also apply to other SUD, substance use disorders outside of the alcohol space.
There has been some research around this. And I think there's probably more research that needs to be done around brief interventions. And hi, Manuel, he was on my team at the SUD Ventures. But at the for like cannabis use is another area where I see this could be potentially viable. In giving people some feedback and information about their cannabis use. We see that these types of brief interventions do not work for people who are using beyond recreational use of other substances, whose substance use has become more problematic. It's been tried to, in like hospital settings when people with, substance related emergency presents to the ER, they've tried to, capture this. They were hoping they would be teaching moments for these patients. But it's not really worked out that way. And I think a lot of times there are other psychosocial and social determinants of health factors going on there as well that kind of swamp the efficacy of the intervention. But I, would be definitely interested in looking at this type of approach for cannabis use, since that is very, very common and becoming problematic as well with it.
Yeah, definitely. So one more question about the information or data on PCP activities in response to the screening results.
Yeah.
Have you been able to collect that information in your trial? And did you see any differences? Was there a proportion who talked with the patients about the results and anything else you could share?
Yeah, I think the feedback we did in focus groups with the providers was they were so relieved not to have to do this on their own, or to have some guidance about what they needed to do. And so, when we told them, you need to screen your patient again in 3 months to see what their drinking level was like, they were just relieved to have that exact information for them. And so that was super helpful, as well as, this patient needs a referral to the UNM addiction and substance use treatment program, as well. And here's the contact information, and please call this number to schedule an intake. So we tried to make it as easy for the providers as well. I was just looking to take, as I'm scooping things off their plate in the primary care provider setting. And the other thing I want to mention is this generates a revenue stream for the healthcare system as well. These are billable services. So that was when we wrote our phase 1 application, we laid out the CPT codes that could be used to bill for these services. Of course, we didn't bill for it because it was a research study, but this is a line of revenue for healthcare systems. And the administrators, that was what was most surprising to me, was how happy they were to have this type of product available in their clinic. So this impacts healthcare and hospital systems HEDIS scores. So these are a quality metric. And they want to just know that people are being diagnosed with substance use disorders, so that there's appropriate screening and things going on that potentially helps with their management. And so the better quality metrics that a hospital or a healthcare system has, the more they can negotiate for reimbursement from health insurance companies. So, anything that can be focused on improving healthcare systems quality metrics, they were pretty keen on. And so that was something that we went into. We knew this would help HEDIS scores and things, but what totally surprised us was how happy the CEO and the CMO of the hospital were that we tested this in.
So it sounds like there are really good financial incentives without which you can't actually scale any products, but
Right.
these are in place for this this product. A question we received is, since we do have a relatively global audience, though this is really designed for the US market, but did you have any insight on sort of the other, sort of how this primary care choke point can be addressed in other geographies? And it's okay if you don't also, as I know you're very
Well, I think I can maybe say a little something, these recommendations for addressing this issue come from the World Health Organization. So, and it's a population type of approach to addressing high-risk alcohol use. And so these standard, like, for example, the audit, I think has been translated and validated in tens of 40 some different languages, I believe. So this could conceivably be a process, and a product that could be, implemented more globally, conceivably for sure. But this type of approach is definitely for addressing high risk and harmful drinking in any population.
Thank you. So I don't have any more questions. I think we have mostly run out of audience questions. I did have a few requests about sharing your contact information. We will share the slides and this recording afterwards. So if you have something that you're working on where you think that there may be some synergies with Brandi's work, feel free to reach out to her. Specifically, there was somebody from a Techstars-backed venture developing a platform for new method regarding excessive drinking. So anything like that, we do want to facilitate connections. Thank you so much, Brandi. Maybe we can wrap up with any asks out there. I don't know, maybe there's somebody in the audience who could be helpful in any ways for this specific project for you, in what you're looking to achieve next, and do you need any collaborators or resources?
Yeah, I would love to hear from anyone. My email address is on the last slide here, so please reach out to me. We're still determining who will be our development partner in this. So if anyone has any interests or that's their particular skill set, would love to talk for sure with that.
Okay, great. Thank you.
Yeah.
And with that, thank you so much for your time. It's been great to see such a heavily attended webinar. It's a very specific topic. Thank you, Brandi, for your time.
Yeah, thank you.
And everybody here, just wanted to remind you that we are looking forward to the next year of SUD Ventures. Our cohort is growing strong. We had 34 people in the first year and about 66 people in the second year. So it's over almost 100 people in this group and growing. We will have applications opening up later this year, most likely closer to the summer. And if you're interested to know what's going on or attend further events around this space, please feel free to sign up to our wait list here. Melly will share the link, and reach out to our team with any questions.
Thank you, everyone, for joining today. And thank you so much, Brandi. This was really amazing.
Thank you very much. It was a lot of fun. And I highly recommend the boot camp. Highly recommend it.
Thank you. Yeah, it was a quick question about when, how long this is. Usually we start in October with live online sessions, and the actual program is in January of every year, and is a full week at MIT here, working with teams on developing SUD-related solutions. Thank you, everyone.
Take care.
Bye.
Bye, everyone.
Bye.